That's very efficient. Okay, you're very welcome to this session. My name is Claire Hayes. I'm really honoured to facilitate it and looking forward to this, what I know is going to be an excellent conversation with 4 really experienced and enthusiastic people in the field. So we're looking at, just to keep me right, the impact of stigma on mental health. That's what this focus is. And we're exploring how social attitudes and misconceptions affect access to care, treatment outcome, overall well-being. And we're doing that so to come up with some strategies to combat stigma, promote awareness, create an inclusive environment that supports mental health for all. So that's the plan. And I know, as well as having 4 experts up here on stage, we also have each of you who are experts in your own field. So we'll start with a conversation with our 4 guests, and then we will move it to any questions that you have, and I really encourage and invite you to participate. So we have here Deirdre Cheallaigh, Olivia Teahan, Ben Adams, and Dr. Frédérique Vallières. I almost got it right. So Frédérique. And rather than me reading out their bios, I'd like to start with giving each of them an opportunity to explain where they're coming from in this session today. I'm always interested in why do people do what they do, what interests them, what's their passion. So Deirdre, because you're beside me, so you're Beyond Stigma. So if you can give us some information, please, about yourself to set this in context.
Thanks, Claire. Lovely to see all the familiar and faces out there. Deirdre Cheallaigh is my name, Beyond Stigma, head of programs. What brought me to this work, I suppose I have a background working in overseas development, in both HIV and gender equality, women's empowerment for a long time. And about 10 years ago, a little more than that, I was living and working in Zimbabwe and managing a program on HIV and human rights, which had an objective in it around stigma reduction and discrimination, so looking at laws and policies as well. And I thought, yeah, that's great, that'll do the trick. I thought it was well designed, well thought through, etc. And then I met somebody who was undertaking a piece of research at the time here in Ireland around internal stigma and HIV. And I listened to that person presenting their findings at a kind of technical meeting I was at. And I realized to my absolute horror, we had this, to my absolute horror, that there was absolutely no way that there was an effective strategy in my program to do anything to support people with internal stigma. I'd fallen into that awful trap of thinking that if you address the world outside, the policies, the laws, work with the health workers, the community, that would have an impact on internal stigma. And it was a real kind of lightning bolt moment for me. I didn't know what I was going to do, but I knew I was going to do something to try and develop or find a strategy that would make an impact on internal stigma. And that was, I suppose, the genesis of Beyond Stigma. And we went on then. That person and their research is somebody known to you all, Nadine Ferris-France, now Dr. Nadine Ferris-France, and we co-founded Beyond Stigma together formally about 9 or 10 years ago. So that's it, yeah.
That's great, thanks Deirdre. And Olivia, you're involved with Nasc Ireland, so if you could give us a context as well, that was really helpful, Deirdre, thank you.
I felt like clapping. That was a lovely intro to what you've been up to. So, thanks for that intro. I'm working in Nasc, the Migrant and Refugee Rights Centre in Cork. So I do their policy and communications work. They support people from all migrant backgrounds, and they've been functioning since 2000 because there really was no support at that time. And obviously the kind of landscape has changed a huge amount over the last 24 years. So yeah, I'm sure we'll get into the kinds of issues that come up there with stigma in a little bit. But the second hat that I'm here with today is around sex education, sexual well-being. I'm a sex educator for adults, and I am a trainee psychosexual therapist as well. So 2 different hats, and I'll maybe be answering different queries for each one. And just in terms of how I got drawn to that work, a lot of my work has been public relations, communications work, because I love talking. And when people are refusing to talk about something, I can't help but wonder why and want to tackle that. So I guess that's why I've been drawn to kind of more taboo topics, I suppose, and particularly in Ireland. I'm just really interested in how we deal with stigmatising health topics, and find it extremely frustrating when it impacts people's health. So. Yeah.
That's great, Olivia. Thank you. And Ben, I know you work with the World Health Organization, so if you can flesh that out a little bit more for us, please.
Yeah, absolutely. I suppose of late I don't work directly or specifically with stigma or around stigma, although I have done extensively in the past, especially in work I did with a disability inclusive organisation. However, I think anyone who works in mental health feels the impact or effects of stigma, whether that's on people, the fact that stigma affects people accessing care or the quality of care that they're receiving, or actually affects their mental health due to discrimination and negative attitudes. The work I do currently is around increasing access to mental health care in low-income countries through a program called the WHO Special Initiative for Mental Health. Nearly forgot it myself. But as I said, for nearly 10 years now, I've been involved in mental health programming, both in terms of development programs and MHPSS programs. And across that, you see the impacts of stigma can have, as I said, both on access to care, but also on quality of care, and just on people's lives. And it's still an area, obviously, I'd be very passionate about. Yeah.
Okay, great, thank you. And Frédérique, I know you work in Trinity College, and you're very involved in research into this area. So if you can give us a context of that, please.
Yeah, absolutely. So my name is Frédérique, and I am the director of the Trinity Centre for Global Health. So as a centre, we're co-located across the schools of medicine and psychology, and we do quite a lot of research around mental health and psychosocial programming in humanitarian contexts, but I suppose also in low-resourced settings. I suppose my own research is focused on, individual, group, and system-level responses to challenging events, whether that's a natural disaster or a traumatic event. But we also have a number of other researchers that are here representing the centre that tend to do a lot of work around, the intersection between education and psychology or psychosocial programming, around how do we care for our carers, right? How do we make sure that the people that are providing mental health services are also cared for? We can talk a little bit about the stigma around, asking for help within your organization as well. I know we're surrounded by clinicians, humanitarian workers, police officers, people who work in professions where there's a lot of bravado, and asking for help can be seen as a sign of weakness. I'm not a stigma researcher per se, so I will kind of provide that caveat. But this promises to be an interesting conversation, so thanks for that.
Thank you very much. Frédérique, I'll get you to keep the microphone for a moment, please, so we'll go back this way. And so in thinking of this session, I really would like to know a few things. So first of all, what brought you to it, and the challenges that you're experiencing, and then the interventions that you found that are particularly helpful, and then maybe suggestions, recommendations that you'd have for ourselves, and then we'll open it up to the floor. So rather than taking all those three together, maybe if you could, just from your own experience, talk to us about challenges that you've noticed in this area, please.
Okay. Where do I start? I suppose resourcing is a challenge for everyone, but mental health is a neglected area of health. We don't have health without mental health. particularly within our, I suppose, allocation in terms of our health budgets. Mental health is consistently underfunded. Within the humanitarian response sector, mental health is consistently underfunded. We have a dearth of human resources for health globally, but we have a particular dearth of human resources for mental health. So some of our work is also looking at how we can share task sharing models, but also how we can bring mental health back into, or caring for persons with psychological distress back into community settings. And that also means, I suppose, providing support for carers as well. It's not just about, you know, okay, take this person or take your family member home. We need to scaffold that with appropriate supports as well. So I think those are all kind of big challenges and having to do with human and financial resources.
Okay, great, thank you. And Ben?
Where to start? I suppose I'll try to stick to stigma, maybe from what I do know, just because I agree with Fred. I mean, I think resourcing and capacity are huge issues across the board with mental health, not just specific to stigma. I think with stigma, quite often over the last few, maybe not as much recently, but some of the stigma work we have been doing, I think sometimes is slightly misinformed or isn't enough. I don't think specific to stigma and mental health, we had great evidence, and I think we now do have better evidence about what works and what doesn't when it comes to combating stigma, and we can get to that. I think in a lot of the contexts many of us would work in, I think one of the challenges when it comes to stigma is that, well, it's multifaceted, but one is that obviously stigma is present at a policy level, and you know, negative attitudes and misconceptions and poor perceptions about people with mental health illness begins at the community level, but goes the whole way up to policy level. So it's, you know, really difficult if you want to tackle stigma in some of these contexts. You know, where do you start? Because you have to do a lot of awareness raising and capacity building at a policy level, but you also have to work closely with communities. And I think one of the other big things is that we, unfortunately, over the years, have been guilty of, in the interventions and the programs we implement, I suppose at times we could be accused of contributing to like the homogenization of mental illness and suffering. And actually that contributes to stigma and discrimination. It doesn't do anything to help it. So I think we have to be really mindful in, even if you don't work specifically in stigma, but you work in mental health or MHPSS, but what you are delivering and how you are working with these communities is culturally appropriate, is developed in participatory ways, and that these people actually are, I suppose anything you're doing aligns with values and beliefs of that population and culture. And that in itself can start to combat, you know, stigma and stigmatizing beliefs. But yeah, I mean, the list goes on.
Yeah. Great, thanks Ben. And Olivia?
I might just pick up on the last bit about like having, I suppose, people who are, you know, nothing about us without us, and having people actually be represented in decision making at a policy level, and also like in, you know, with the local elections, we saw a lot more push, for example, with the with different candidates from migrant backgrounds, and there's different issues that will come up for people in that setting, you know. That just contribute to stigma as well. Like, for example, there's been research out now this year about the kind of gendered and racial abuse that people are exposed to. So that's definitely a challenge in terms of those kind of cross or intersectional issues that people are up against when they are actually trying to represent their communities and be at the table. So that's certainly one challenge in terms of, you know, also to talk about maybe the last a year or two, the kind of climate that we have at the moment for people who are perhaps in the international protection system or from any kind of ethnic minority background in general or migrant background. You know, we have a political climate at the moment where it's become much more acceptable to say things publicly that are quite scapegoating of different populations and put a lot of blame on those populations. So aside from stigma around mental health, there's stigmatizing of populations in general just for existing in this country. And, you know, you can imagine if that's a pressure that's on someone already, that they're hearing that from their political leaders, to then be thinking about the personal mental health issues they might be having and accessing services. It's not very inviting, you know. So that's certainly a challenge that I suppose is increasing at the moment. And we also have an issue, I suppose, for our own service users at Nasc around the system that they're in for people when they're arriving in Ireland. A lot of institutionalised living in the international protection system, for example, and all of those things separate you. They separate you from broader society, they prevent integration, and that certainly has a knock-on effect on how stigmatised you are in terms of mental health issues. And then separately, I suppose, just briefly for our sexual well-being in Ireland, the stigma there is long-standing, and the fact that we have the history that we have with sexual disempowerment and abuse, and we do not have the specialist services to kind of respond to that is really, I don't have the words for it. I think it's hard to believe. We have one publicly funded part-time psychosexual therapist in this country, and it's something that we're only just starting to talk about now. We're starting finally to talk about, okay, we need to be talking about consent in schools, okay, we need to be providing more menopausal and reproductive health supports. It's a very, very late conversation that we're having on that front. So even though, yeah, we'll talk about some of the solutions later, but those are some of the challenges.
And Deirdre, before we move on, could you just, for people who've never heard of Nasc and who don't, could you just give us a quick synopsis, please?
Yeah, sure. So Nasc is based in Cork. They are working with migrants. So I've been talking a lot about people seeking asylum or protection, but we also work with migrants from all backgrounds and situations. And we would provide an advocacy service which supports people who maybe have just arrived in Ireland or maybe going about family reunification. We also have a social work service which supports people, young men who are maybe seeking employment and training opportunities and aren't sure how to go about it. And then family reunification social work service as well, because there can be a lot of issues that come up if, for example, you haven't seen dad in lots of years, you're, maybe a young teen yourself, you're after, you have different cultural influences now, and then when you have family reunification, and it's a really important time of celebration, but there's lots of differences and changes. So our social work team do brilliant work on that. We have a Ukraine response team. We have a women's project which does practical financial literacy, crafting, cookery skills, and supports women who are typically socially excluded, women from migrant backgrounds in Ireland, socioeconomically and otherwise. So yeah, supports over 160 women, I think, at the moment. And we have, as part of that, a women's empowerment project which supports self-advocacy and political awareness for migrant women. I am wondering if I've forgotten any of my colleagues, they'll kill me. Our community sponsorship program is really, really exciting. Hopefully I'll mention that a bit later, but basically it's encouraging local communities around the country to support and welcome the arrival of refugees in Ireland. So it's a really interesting program around integration, and I will follow up on that a little bit for our solutions, because it's a nice, wholesome one.
That's great, thank you very much. And Deirdre, I know for me one of the biggest challenges to stigma is self-stigma. What have you found, please?
That you're absolutely right. In Beyond Stigma, we work with marginalised, excluded and vulnerable groups on sensitive issues. So that's the challenge. And we do that globally. So in various locations in Africa, but also in Asia, with sex workers, with people who've had TB, with people living with HIV, adolescents living with HIV, here in Ireland with people living with obesity. You introduced us as experts and also referred to the people in the room as experts earlier. We absolutely are all experts in internal stigma. So if you've ever had the belief that you're not good enough, you know personally and you feel deeply what self-stigma is. That is the challenge. Ben mentioned working at multiple levels. It's absolutely necessary. This is deep individual work because we're talking about beliefs, thoughts and negative self-judgments that absolutely permeate and are insidious and affect the way in which you live your life, how you interact with others, how you do or don't avail of life's opportunities. So it's a challenging issue in itself, but it is, not to come on to solutions, but I'll talk about it later, it can be addressed. Resources were mentioned earlier, and absolutely, it's not quick work, it's deep work. The effects are transformative and lasting, so it's worthwhile work, of course, but, and I think as a sector, I mean, if we take HIV as an example, we're 40 years in or more. We did a systematic review of the interventions and the evidence that's out there. There are 35 studies of effective or interventions at all, and the results of those that addressed internal stigma in relation to HIV. So while we have made great strides with strategies like U=U and the impact that those have had on stigma and internal stigma as well, we have an awful lot to learn and an awful lot more to do. The value for money agenda is something that we crash up against all the time. The kind of emphasis on quick results, tangible results. This work doesn't feel like that, and it doesn't look like that. And we need to kind of support ourselves to see that this is kind of deep work that takes time, has a different look and feel to what we're used to, you know, in the health sector, in the global health sector, in HIV, in GBV work. Scalability is something as well. How do you take these interventions that do work, and we've been presenting over the last day or two on some of the work that we've been doing, but how do you make that accessible in a safe and in a responsible way to, you know, communities and to individuals? How do you do that in a way that absolutely builds on the strengths in the local communities, leverages what we've been doing and doing so well for so long? Support groups, HIV support groups for migrant groups, support groups for survivors of violence. There is infrastructure out there, there are things that we know how to do well, but how do you bring this piece to it and deliver at scale? Some of the challenges, there's obviously more.
Thank you. Frédérique, are you okay if we just go that way? I was going to break it up a little bit and go with Ben next, but I'll go with you. Thank you. The session this morning was incredible, and I was really relieved myself that it finished on some, as far as possible, a note of hope. And we could get very bogged down talking about stigma right across the world, and particularly if we go into the area of self-stigma. So could you talk to us, please, from your work, what you have found is really giving you a sense of hope?
I think that's a really good question. I do think, you know, in terms of maybe touching a little bit on what works, I think is kind of what you're getting at, what seems to be kind of working, right? Obviously, the self-stigma component is some sort of reflection of what's happening outside of the self, right? We're, you know, to some degree, we are having this kind of internal dialogue with ourselves, which is a reflection of, you know, what we're picking up from the outside. I do think there's been, you know, quite a lot of work that's been done around the normalization of mental health. And I mean that in the sense that, you know, at any given moment, 1 out of 7 people globally will be, you know, meet the criteria for some sort of, you know, mental disorder, however we want it to check. So it is a very common occurrence. You know, it is common in this room, it is common globally. You know, it is something that is experienced in our families, it's experienced in our friends, and that kind of normalization, I think, is really, really important because it gives us the language to recognize and to talk about mental health. So I do think that for me is a positive. You know, some people might argue that we talk about it too much and now it's become almost this like contagion. I'm not sure I agree with that necessarily. I do think it's important that we talk about it and that we normalize it. You know, we've looked at campaigns like, you know, even within the police service of Northern Ireland, which is, you know, it's okay not to be okay. These types of advocacy programs where peer support groups have been shown to be very promising and very effective. Occupational health and well-being outside of one's organization, also really important. So where do we kind of signpost people to go for help? I think those are all really kind of hopeful elements in being able to address mental health, but also the stigma that kind of comes with that.
And I know you're involved, you're the principal investigator in 2 key projects. Would you be okay to give us a snapshot of those, please?
Sure. So Chad presented on one of them today, which is the integrated model for supervision, and this is specifically targeting humanitarian workers that work in mental health and psychosocial programming. Again, making sure that, that they have the supports that they need to be able to, tend to beneficiaries. So in other words, that they have support structures in place to ask for help, to talk about what they're seeing, to talk about what they're experiencing, and to kind of voice that it's, it's okay not to be okay. And one of the things that came out really strongly as a result of this is that, we're not talking about your supervisor in a managerial sense. This is someone outside of your management. This is not your line manager. This is someone who's provided to you by an organization where you can debrief and you can have those difficult conversations about what you're seeing, what you're experiencing. And obviously from the speakers this morning, we see that, some of the things that people are experiencing and witnessing in their family, their friends, themselves, it's very, very difficult at the minute. It's, beyond some of our imaginations and worst nightmares. So how do you then kind of keep going and keep providing mental health supports to others? And so that supervision model is something that we are looking at very closely. In the past, we've also looked at how do we bring mental health and psychosocial support into schools. We had a project funded by the European Commission that was looking at how do we do this for forcibly displaced persons to Europe, forcibly displaced children to Europe, making sure that we are fostering a sense of belonging. How do we bring psychological first aid, which Quiva spoke to this morning about, into schools, training teachers on how to recognize children that are exhibiting signs of distress, not behavior problems. These are signs of distress potentially in children, and how do we address that? So these are just a couple of the different things that we're looking at. But yes, the importance of integrating kind of mental health awareness into education, into primary health care, which we've talked about extensively. Yes. All of these things are hopeful to me.
That's great. Thank you very much, Frédérique. So Ben, the World Health Organization, literally the words, World Health Organization. So can you fill us in on what you've been doing and that gives you hope and that you find is working in terms of interventions, please? Yeah,
I think one thing linking back maybe to what I said earlier, and that something that gives me hope broadly around stigma is, well, something Fred said in that we are all talking about it much more. And I agree. I think that can do nothing really but good. I think, yes, it's nuanced slightly, but I certainly don't think we should be discouraging that. We need to be encouraging it. But the other thing is what I mentioned previously around we really now have evidence about what works when it comes to stigma, especially and specifically mental health stigma. The main, I suppose, there's so much. What we do know is there's so much we can do, and so much great work happening out there. I'll stay in my lane, I suppose, in terms of mental health development work, but things, that we know work include, it's actually some things that people may not think of. So even if you're not directly working on a stigma reduction campaign, but you're working in mental health programming and you focus on integrating mental health into primary health care, for example, which is a focus area that WHO is focusing on at the moment, that in itself can actually contribute to stigma reduction as long as you do it in the right way. So as long as your work to do that is participatory, as long as what you're integrating is culturally responsive and is accepted within the community, as long as it's human rights focused, and as long as it's accessible, that in itself, that integration into primary health care in all communities can actually work towards reducing stigma. Peer support, I can go on, there's such a big list. Peer support interventions not only work to combat self-stigma, but they also work to combat stigma more broadly in the community. And things like Fred was speaking about around, integrating mental health interventions or awareness raising at education, and quite young in someone's, with children and adolescents has been proven to be really beneficial when it comes to stigma and self-stigma. But more recently, I suppose what the evidence is really showing us is that awareness campaigns on their own, while they do support correcting, if you like, misinformation around mental health, they don't actually have any really significant impact on attitudes. And I think that's really what we need to be shifting. So people might have the correct information, and for me this is actually slightly more worrying, is that even with the right information around mental health, their attitudes may not change. And what the evidence in recent years has really shown us, and I'd urge anyone who's interested in this area to look at, it was a Lancet Commission article, I think, earlier this year. The lead author is Graham Thornycroft, who's done a lot of work in this area, is that social contact with people with mental health conditions and sharing stories is actually what has been shown to change attitudes and to increase empathy levels for people with mental health conditions. And that is really what we need to be promoting. So I suppose, yeah, look, I could go on. There's so many things we could be doing. But that, for me, if there's one thing you want to do, or if you want to focus on stigma, then social contact is really the way forward. Yeah.
Okay, that's really helpful, Ben. Thank you. And Olivia, you've had a chance there to think. What would you like to add in terms of the work, both hats that you've had?
Yeah, I wasn't thinking, I was just listening to those points, and I'm going to copy yours, Ben, because that, that practice of having more social contact with people who you've somehow othered is just that, it's like, and I mean, I think that goes with, and I suppose like when we're talking about mental health as well, like, you could be having you're having social contact with people who are experiencing or have experienced very intense mental health issues anyway. You just don't realise it. And I suppose that's where this othering can come in as well. Like we think that you're going to be able to notice straight away, and that's just not the case. And being able to just recognise that is even like, getting us a little bit closer to say when you see the child who's having the behavioural and you're able to see like, no, this is a sign of distress. So I think, we're talking about challenges. I really wasn't thinking, I was just listening to what you were saying. So I suppose then in terms...
what you found that works?
We've moved on. We're going to solutions and hope. I'm back in the room, lads. I'm back in the room. So for solutions then, so I suppose, the othering really in terms of people from a migrant background is, again, comes down to the social contact. We can be doing all the policy strategizing and all that we like, and again with the comms campaigns and the awareness campaigns and all that, but especially when I'm in the kind of communications and media side of that work, it's the clickbait and the scary stuff that gets shared. But there's thousands of lovely, beautiful stories happening every day all over the country of different communities, different populations bonding and integrating and or just being part of the same community, in an integrated way. But a lot of the time we don't hear about that stuff, but it is happening and it's real. And a lot of that stuff comes from more informal, unpoliticized environments as well. There's an amazing group, the Sanctuary Runners, who are all over the country now, and they just encourage people to come for a run, and they just name that it's open to people from different backgrounds and just really encourage people to hang out and have a chat or just be running together for half an hour every week. And that stuff makes a difference. That stuff is what then prevents someone who, if some kind of, for example, anti-immigrant sentiment has been kind of weaponized in their community, and I was talking earlier about that scapegoating, when you can remember though, I actually went for a run with your one last week though, and she was sound, and I felt like we kind of, had a good chat, or it just blocks it a little bit. It blocks that kind of misinformation and myths and kind of fear-mongering, I suppose, from kind of going in, and what Ben said about, we can have all the information in the world, but it's the narrative and the feeling really that is what's going to change your attitudes. So that is, I think, really key. And then in terms of the sexual wellbeing solutions, I have found that it's growing. There's a lot more people speaking about solutions publicly. As I said, we don't have those publicly funded specialist services happening, but there's plenty of people working in sexual wellbeing in Ireland in different areas. There's amazing healthcare practitioners who are really passionate about sexually empowering people, about being able to have very normal, like standard conversations in their consultancies, and also for more specific sexual issues, like it can be really difficult to access someone to get an appointment, to be able to pay for it. There are online support groups happening in the country around specific issues, and there are ways to get information and support on stuff now, even if the services aren't quite there yet, you know, so that does give me hope for sure.
Okay, great, thank you. And just to give yourselves hope that you will have a chance to say something, I'm going to ask Deirdre to answer that question as well, and then open it to the floor. And then each of our speakers will have an opportunity to finish with what they want as a takeaway point, what point they'd like to make. So obviously you're going to stay in the room as well while Deirdre's speaking, but you might want to think about your question as well. So Deirdre, what have you found in your work that gives you hope in terms of interventions? Thanks, Olivia.
A huge amount. And I just echo or reinforce what's already been said, the normalisation of and the conversation that's happening. For those who were in Munich in July for the International AIDS Conference, that was palpable. Talking about kind of our expectations going from kind of surviving to thriving, and these ideas of flourishing and, you know, positive health and well-being. All that kind of, you know, that's hugely positive. The evidence that Ben mentioned, and it's growing. We're contributing to it, and that is hugely important and really positive. We can leverage it, we can build on it. Things like support groups that have been mentioned, absolutely, in terms of building self-esteem, that connectedness, the social contact with people with lived experience, that is absolutely really positive as well. What I would add is, in the case of internal stigma, just to note that all of those things can happen. A person can be in a support group. A person can have social contact and be connected with others and will experience a sense of improvement. However, it is also important just to reiterate that self or internal stigma, it can exist, and it does exist in the absence of external stigma. I don't need to experience social or public stigma to feel that I'm not a good person and I'm not worthy. And what gives me hope, I suppose, is that when we see people move or make that shift from internal stigma, what comes out on the other side, or what that looks like, is self-love, self-forgiveness, self-empathy. And those aren't just lovely things to talk about. They give people a huge sense of agency. So what you'll see are people who absolutely grab life by the hands, by the shoulders, shake it. They'll enroll in courses. They'll, you know, entrepreneurial spirit is what you'll see. Relationships improved, communication improved. They are their full, true selves in the world, and that is a mighty thing to witness. And that would give anyone hope.
It's great, Deirdre. Thank you very much. So now open to yourselves. If anyone would like to ask a question, please, or make a contribution. Nadine? Or Doctor? Oh, thanks, Nadine. Okay, guys, lunch break is just gone. So what really struck me while I've been listening to each of you is one sentence. Let there be peace on earth, and let it begin with me. And I think it's really easy to look out there for the world to change. And I'm very much struck by the importance of us looking at what are we doing to ourselves, torturing ourselves, limiting ourselves, blaming ourselves, condemning ourselves. And if we can be compassionate towards ourselves and focus on helpful action that we can do, and if each of us can do that, then things can change. And absolutely, stigma, I'm thinking, I was also listening very carefully, and I was thinking of a young girl I know at the moment who is 11, who is in hospital with anorexia, and just how she is hating herself, and how her experience is replicated with so many people worldwide. And I think in terms of stigma, we can easily understand, or more easily understand, stigma as it refers to maybe leprosy in years gone by, where people had the bell. And now COVID, you know, there's still a sense of, oh gosh, somebody's coughing. I did a COVID test yesterday because I had a sore throat, and I thought, I don't want to come here if I have COVID, and I don't. But the sense of not being welcomed among you, obviously, if I did, that's become, our own health has become an area where we might feel stigmatized against. So for me, in terms of interventions at work, I love cognitive behavioral therapy and really coming back to the balance between, I've a sentence developed, the ABC coping sentence to explain this. So A, acknowledging, I feel overwhelmed. B, because I think there's so much sadness and tragedy in the world. And then C, but I choose to do what I can do, at the best that I can do it. And I think, Nadine, that sums it up in still time for lunch. Thank you. So that was not a plant, but I think it might have been. I just didn't know it, didn't see it coming. Is there any other question? Yes, lady at the back, thank you. Oh, I spoke to you this morning, so I should know your name, but I'm going to get the pronunciation wrong.
Hi, my name is
Wait, Dan?
Pop the mic real quick. Sorry.
Can you just hold for a moment until the microphone gets to you? Thank you.
It's a long way.
Thank you. My name is Wigtan. I am one of the student outreach, originally from Sudan. Thank you so much for the presentations. And my question probably for all of you, including you, Dr. Claire. I was just talking about what happened in Sudan back in 2018, in 19, actually after the revolution. And it was this big incident. Sadly, it's still going on. And the stigma among the Sudanese, I would say, you know, later maybe people will know the magnitude of what they are carrying after the disperse of the sit-in, if you remember, back in 2019. And in that incident, lots of people who were giving good things to the Sudanese community, like women got raped, doctors in their clinics, pharmacists, medical students, engineers, artistic people, name it. All of them, they got hurt. They got raped for definitely, because there were groups, you know, working on that. I was just wondering, and I want you to think, you know, with me, where are these people? What the magnitude of the stigma they are carrying? Probably some of them came here, came to any other European country. I was just wondering, would they be still able to be giving people like before? And how they are going to, you know, just get the load off their shoulder, how they're going to get help. Would they be able to talk about it? You know, a doctor may be working here in Ireland or in anywhere. It happened to him or to her anywhere. So it is, are they recognized by us, you know, by those who could help them? There is a lot, I think, going inside me. Maybe I wouldn't be able to put it in words, but I don't know. I was just wondering, what could we do for them? Or would we be able to do anything for them later? Or they would be able to cope with what they are carrying? Thank you so much.
Thank you. If I heard you correctly, I think what you've done is very, very skillfully raised attention to, we need to keep our focus on people who have been damaged in the past and not just suddenly move on to the next and the next and the next. So this is a lifetime's work and really respecting people where they're at. I'm conscious of time, so when I finish my work, and I'm privileged to do it, I always ask people to ask them how is this for them, and to tell me one thing that struck them as helpful. So, Deirdre, if you don't mind, one thing in this conversation that struck you as helpful.
I suppose the strategies and the richness, I mean, this is an area that we've heard from right across the panel, and absolutely without a doubt in the room, the strategies, and we're building up such a kind of a repository of techniques, evidence, strategies that can and do work with different groups, different population groups. So that for me is what I'll take away, sharing and kind of just, yeah, coming together around that and building that repository and continuing to do so.
I think I take when we were talking about hope earlier, I was thinking like I get hope every day really from my colleagues. I know that sounds a bit cheesy, but the work that they're doing is like, it's very inspiring to see, especially when like we're all up against some very, very heavy stuff. It's good to know that some people are absolutely relentless and just are not gonna stop, you know, and just reflecting on a few of the kind of more evidence-based solutions that were brought up today, that is also very encouraging, you know, and that is still, like, it's progressing so much what is happening in research and in bringing all of the, you know, really useful minds together. So we don't have a lot of the solutions yet, but they're coming, which I think is nice. You know, we don't know yet how we're going to approach some things. And also, if that lady would like to have a little chat afterwards, I'd love to discuss what you brought up. Cheers.
Thanks. I'm going to go a little bit rogue, Claire, sorry. But just in response to our colleague from Sudan, I think it reminded me of a conversation I've been having a lot lately and even had with a few people outside around the need for us, especially, for example, in Ireland, to really start thinking more about how we are going to provide services and support people who are here as asylum seekers or internally displaced or international protection applicants, etc. And I am saying that, I'm even linking it to stigma in terms of expecting that services that we currently provide are going to be accepting for those people or acceptable to those people, actually can further perpetuate issues around self-stigma and stigma. So something we need to be really careful of here is that, that we're aware of that we have a huge lack of appropriate services that are appropriate, I suppose, for the diversification of our population, which we are gratefully seeing now at the moment. But also that we, as people working in global health or mental health, and it's not just even mental health specific, need to be mindful especially if we're working in a clinical capacity, that when we're engaging with these populations, that we're making sure that what we're doing, what we're providing is appropriate and suitable to them, but also that we're encouraging conversations around their past and their history and where they have come from, to support them to go out into the world and do that further. Sorry, I'll stop now in a second. The last thing I suppose just to say, and it's linked to your question around hope, is that, and I think we've all kind of spoken about it, but there is much, much more evidence now than there ever was around how to combat stigma. And I would really encourage people to engage with the resources that are out there. I know that Beyond Stigma's website itself is very good and links to other resources as well. Next week on World Mental Health Day, WHO are launching a mental health stigma toolkit to support individuals and organizations in challenging stigma and discrimination when it comes to mental health. I'd also really encourage people to look at the Lancet Commission article I discussed. And the other piece as well is, it's actually not in operation anymore, but if you look at the work that an organisation called Time to Change did in the UK, that then went to multiple countries once it scaled up, they have some really strong evidence, especially around the social contact piece that we discussed, about how that works and the best way to go about actually implementing programs for stigma reduction across different population groups and communities. So there's loads out there, so I'd really encourage people to engage with it.
What to add after all that? I suppose one of the things that's come to my mind is the fact that you've raised a really important point around gender-based violence and sexual assault and the stigma that comes with that. We've spoken about your previous life in disability and the stigma that's attached to disability. So not just to kind of think about mental health stigma on its own, but it's kind of intersectionality with other areas that also carry stigma that are very tightly intertwined with mental health stigma as well. And so how do we start to kind of look at that more holistically, I think is something I'm taking away from this. Thanks.
All right. Thank you very much. So I would just like to say Comhlámh Magadh to all of you for your attention, and each of the speakers I know would be very willing, I'm assuming, to answer questions. And I would like personally to wish Dr. Nadine Ferris-France and her colleagues the very, very best in the Irish Global Network and in Beyond Stigma. And enjoy your lunch. Comhlámh Magadh. And thank you for each of you.